Okay. My name is Reed Thompson, and I'm an associate professor of pediatrics at Johns Hopkins in the Pediatric Cardiology Division. And I'm very pleased to talk to you about a study that we have done and are doing involving auscultation. And Therese talked about updating the use of the ophthalmoscope and the otoscope, and I'm going to talk about the same thing for the stethoscope. So I have no disclosures. I will discuss an algorithm, an AI algorithm that was developed by CSD Laboratories in Austria. It is investigational. It is now cleared as of 2 weeks ago by the FDA, but not available currently for sale in the United States. And it goes by eMurmur, and that's how we'll be referring to it here. The background for this talk is that experienced clinicians using a simple stethoscope are able to detect pathologic murmurs in asymptomatic patients with valve disease as well as congenital heart defects. However, the auscultation proficiency has declined, making screening for heart disease with a stethoscope more difficult for many people. So AI-assisted auscultation, or AIAA, has the potential to improve the accuracy of screening, yet despite the development of advanced signal processing and classification algorithms focused on the heart sounds, acceptance of this technology in clinical practice is not widespread. So here are some of the advantages of AIAA compared to echocardiography, which is being looked at with artificial intelligence as well. There's a less complex data stream, and the signal acquisition is something very familiar to the clinicians that are going to be using it, as opposed to doing an echocardiogram. You would use an electronic stethoscope. And the published sensitivity and specificities for the available algorithms are actually astonishingly high. But here we are, and these studies have been going on over the past 10 years. There has not really been good clinical studies. And so I think this is part of the barrier to acceptance of using AI-enhanced auscultation. There's no standardized data set for comparing competing algorithms, and most of the validation has been done on the same data set that was used for training of the algorithm. So we have a very large data set at Hopkins, and we're very interested in testing some of the available algorithms. And so we did a study now about 2 years ago, published this year, and we took 603 outpatient visits at Johns Hopkins that we recorded heart sounds from 5 different areas on. Mean age was 9.3 years, and the age was from neonates to an 80-year-old person with a PDA, as a matter of fact. 5 locations on the chest were recorded, and this is stored in a publicly available database called CARD, or Johns Hopkins Cardiac Auscultatory Recording Database. Each study is done with a 3-lead ECG on a separate channel, and we can use that to validate the algorithm in terms of the heart rate estimation. And then for each recording set, for each patient, we have an echocardiogram with all the actual diagnosis the patient had, as well as cardiologist's opinion of what the sounds sound like. So it's a very curated and carefully accumulated set of heart sounds. So for this study, we took 374 patients that had an abnormal echo, and they all had a pathologic murmur, and we, for the comparison, looked at 229 patients with a normal echo. 90% had an innocent murmur, and 139 had no murmur. Now, this algorithm that I mentioned that was developed in Europe used a completely different set of files, data files, for their training. It can be deployed using any recorded heart sound in a wave format, and you must know the age of the patient for the algorithm to work. But it is stethoscope vendor neutral, no ECG requirement to do the analysis. And briefly, the algorithm detects murmur energy through signal processing, estimates the intensity, and localizes where it occurs in the cardiac cycle, then uses certain features from that signal processing as input to a nonlinear AI classifier to determine the presence of a pathologic murmur versus an innocent murmur versus no murmur. The other good features of the algorithm are that there's an ability to reject recordings that have insufficient or suboptimal data, and very importantly, to give a certainty level as to the AI analysis. So in terms of feasibility, the algorithm was able to process and give a determination for 89% of our recordings. And the sensitivity overall was 93% for detection of pathologic murmurs, specificity 81%, with accuracy of 88%. This gives you a breakdown of the murmur intensity, which obviously is one of the features that determines pathology. Louder murmurs are more likely to be pathologic. And as you might expect, the sensitivity is somewhat lower for grade 1 pathologic murmurs. The algorithm had a 75% sensitivity for grade 1, and for grade 2, a 94% sensitivity. Specificity also, you would expect to be more challenging at the higher intensity murmurs. And as you would see, expect to see, the algorithm specificity is 55% for grade 2 murmurs, but 80% for grade 1 murmurs, just in terms of intensity. So in terms of the certainty, which I think is actually a quite important piece of the AI analysis, when the algorithm rated the analysis at its highest level of certainty, 95%, this was the case for 64% or 2/3 of our cases, so not the entire data set. But when it did rate the certainty level at highest, the sensitivity and specificity were 93% and 97%, and the accuracy was 95%. So this potentially could give the pediatrician really valuable information if you could look at that certainty level. So the next steps, we've tried it now on a data set heavily curated, but will this work in clinical practice? So we are now conducting a pilot trial at 4 of our primary care sites: the normal nursery, our resident primary care clinic, Johns Hopkins community physicians, so these are under the Hopkins network, but they are practicing pediatricians, and then the pediatric cardiology clinic. Eligibility to enroll a patient is any patient with a heart murmur and no previous cardiology evaluation or echocardiogram. And the primary outcome measure is positive predictive value of the AI result compared to the referral decision of the primary provider. So in this case, the murmur is heard by the clinician, then recorded using an electronic stethoscope. The sounds are uploaded via a smartphone app to the cloud server managed by that company. They will not have access to the outcome data or the echocardiogram data, but they will just provide an AI analysis. In addition, we're having a cardiologist listen to these sounds, and that's a secondary outcome measure, is how the cardiologist does with and without the AI analysis, because we envision there could be at least an interim model where sounds are submitted for cardiologist interpretation, and then he uses or she uses AI to help with the interpretation, similar to what we do with EKGs currently. So we're in the middle of the trial. We have recorded close to 100 patients already. We expect to finish it up within the next few months and have data by the fall. And we conclude that virtual clinical trials for algorithm validation are very important, and they may assist the understanding of the potential value of computer-assisted auscultation. And our center is doing this study, which will assess the use of AI in several common clinical settings. And I've just included our website. We have a teaching website that uses all of these recorded sounds that we have accumulated over the years. This is the largest database, or one of the largest databases in the world. So I encourage any interested people to look at our website, and hopefully we'll have data from our pilot study within about a half a year. Thank you. Sure. How do you improve the certainty level? Well, we're thinking with the assistance of AI. So we're looking at AI as a decision assist device, as opposed, similar to what we do with EKGs. EKGs have readings. They're not always right. So I think there's going to be a training element. When are the readings right and when are they not? But I think the combination of having this available will improve the certainty of the pediatrician. And as opposed to it just being taken at face value, I think you need to, because there are definitely certain murmurs that we predict will be missed by AI, picked up by a cardiologist, and hopefully we'll have a way of catching those. Yeah, yeah, sure. Yeah. Yes. Well, so with the pilot trial, we're actually looking at both possibilities. But it sort of depends on where you put the encounter with the AI. If you put it in the pediatrician's office versus you give it to the cardiologist and the sounds are transmitted, the cardiologist is sort of the gatekeeper of deciding to use the AI or not. I think it might likely start that way, and as it improves, these algorithms are constantly being updated and improved, just like EKG. Those algorithms began in the 1970s. They're still being modified. So I think when we get to the point where you can take the cardiologist out of the equation, and you can see they're already with the high certainty cases doing better than a cardiologist. So I think eventually it will get maybe to the pediatrician, maybe even directly to the parent at some point. But I think we have to do it in stages. Yeah. Yeah. Okay, thank you.